Good afternoon and welcome to Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, and streaming on Facebook Live. Also thanks to the folks down at CTV3 in Connorsville for being willing to air this information to the community. My thanks also to Dr. David Jetmore, who kind of played musical chairs over the last couple of weeks, moved from his seat into mine, and to Christine Stinson, Executive Director of the Wayne County Health Department, for coming in and taking over Dr. Jetmore's chair. As I think you all still do, it's been a while since I've been here, we'll find out what you've learned, what you've figured out, or what's new during the last week. And Dr. Jetmore, since you're back in your seat, we'll start with you.
Well, you've been gone for a while, Eric, and you're going to be disappointed to find out that the pandemic is still ongoing. I know you probably had hoped that it'd be over when you returned.
I hope.
But yeah, we're still having a pandemic here in Wayne County. Our numbers have gone up, and I'm sure Tom will report the numbers in the hospitals have gone up. The positivity rate in the county is around 5%, 4.9% to be exact, but this compares to 3.2% a week ago, so we're seeing more positive cases. We've opened schools since you've been gone, Eric, and that's as we expected. We're seeing children having COVID and testing positive at school, and we've had to isolate some children. I think a total so far for the entire county is we've had to isolate 170 students in Wayne County. Now, some of them are coming off of isolation. This began earlier in the month. So we're dealing with this. We're finding the children that are having COVID. We're sending them home to isolate for 10 days. We're finding their contacts. We're isolating those children for 14 days. And school is going on. So that's a good thing. School is so important for these kids, not only for learning, but for nutrition, socialization, and many other things. I think school is kind of one of the bedrocks of our society, so I'm happy about that. I think how we go from here depends on our behavior as a society. The governor recently continued for another month his mandate that we should wear masks when we're inside public buildings, or if we can't do that, and to do that outside if we can't maintain a social distance of about 6 feet. So here we are. We find every time in these pandemics, and you can see where people have mapped this out from state to state, when we loosen mitigating strategy, the coronavirus goes up. When we isolate, mitigate, put on our masks, the virus goes down. So there's an obvious correlation, and this is the only tool we have to fight the virus right now. So it's so important that we do these things.
A couple of things you said I want to try to come back to, but I know we've got some questions that have already come in. I want to make sure we get to those questions first. But Dr. Huth, what's new? You're in the hospital scene.
Well, the first and most important thing to me that's new is you're back, Eric. We missed you. Yeah, we had fun, and I hope Dave did. I think it was a little nerve-wracking for him at times, but I think if it had gone on much longer, we're liable to break something because we're like
he never did get used to the voices in his head, huh?
More than usual number of voices in his head. That's what the problem is. But I think, Dr. Jetmore referred to schools have gone back. That is a big thing. That's a constant topic of conversation. Now, I've noticed in other communities where there's a big presence of multiple large universities, they're very interested in what's happening at the universities. And I'm not sure whether I think the local higher education institutions here are starting with online learning and then going back to in-person classes later. But When I pay attention to the national media or the regional media, there's a lot of discussion about what's happening with respect to colleges as kids go back to more in-person education, and there are increasing numbers of cases at universities. I think the issue there seems to be that, on the one hand, the university's plans are very good. What they're doing on campus, what they're trying to teach the students, how to be responsible. The problem probably comes in that students are arriving having not taken many precautions, and so they're testing positive when they come in. Or, a big part of being away at college is the social aspect, and so when they get outside of class, they're socializing in ways that are not productive from the standpoint of minimizing the spread of COVID-19. But I think it's a learning process for everybody. And I think I can detect already that with respect to schools in this area, that everybody's kind of figuring it out and getting used to it. Yeah, we have to isolate students, but there's less panic and emotional reaction now because, okay, here's what we do. We have our plans. A middle school teacher, actually the spouse of a middle school teacher, told me a couple of days ago that his wife felt that her middle school students were actually doing really well with masking and distancing at school, and so she was pleasantly surprised. And that sort of feeds into my thought that with time, everybody's going to kind of get used to it and figure out how to make it work.
Okay. We've got a guest, as you all had guests while I was gone. We've got a guest on Zoom. Dr. Jennifer Bales, Chief of Staff, Chair of Physician Engagement and Resilience Committee, and Emergency Room Physician. Dr. Bales, thank you very much for being willing to join us today on Ask the Doctors.
Sure, thanks for having me.
Well, Jennifer, I'm going to lead off the questioning to you, and I really appreciate you being there. I always like to talk to Dr. Bales about what's going on in the world because she's in the catbird seat, as I like to think of it, working in the emergency room. But in addition to that, Dr. Bales is chief of the medical staff at Reed, so she kind of gets sources of information from all kinds of angles that lead to interesting observations. But I wanted to start with you, Jennifer, as I normally do with interviewees, that to go back to at the beginning of the pandemic, what were things like in your practice and your day-to-day existence back when this was all new, and how have things changed over time, and what's your perspective now compared to then?
Certainly in the beginning, it was just really stressful trying to figure out new processes and new policies and how to keep everybody safe. And that's really become kind of old hat now. I mean, everybody knows that we're going to be wearing masks all the time. We're getting really used to the use of the personal protective equipment, and just the day-to-day grind of it is beginning to feel more normal. So I guess that's good and bad, but it does make the workday easier to just kind of feel used to it. I would say that there have been a couple of positive trends since the beginning. One positive trend I would say is that it seems that the severity of illness in COVID patients seems to be less now, at least in our ER. In the beginning, in April, when COVID patients were coming in, they were just so super ill, and a lot of them were requiring ventilator support in the emergency department, and right away we had to do that. Now it seems as though when they come in, they are still ill, but less so. I'm not sure I know why that is, whether that's because the average age in our community of patients getting COVID is going down, and so they tolerate the illness better, or if maybe the virulence of the disease is going down and it's just less aggressive. We have different ways of we're treating it as well too that seems to be more successful, but for the most part, people seem less sick, which is good. That's a good thing. Another thing that I've noticed that's really different since the beginning is that in April, for sure, people were really avoiding the emergency department. They had concerning symptoms that they were not seeking care for. They were They were really delaying, and that was resulting in increased severity of illness for those patients, unrelated directly, at least, to COVID. So that seems to be better now too. Our volumes are back up to where they were pre-COVID, and patients are coming in earlier with their symptoms, which is always good because earlier intervention is always good for most conditions, and so that's good. On the negative side, the one thing I thought would be better by now that kind of isn't is testing. Testing is still really frustrating. I want a test that I can order and can be back in an hour for everybody who wants it, and there just isn't the supply chain for that, and that's been really frustrating for me. It seems like the testing thing just keeps rolling back around as the supply chain gets delayed and we don't have the swabs or we don't have this or that. It's just that can be frustrating, and frustrating for patients who want to know.
Yeah, it is. And we can talk more about testing later. You know, I don't know if you've noticed, Jennifer, in the emergency room, increases in COVID-type symptomatology over the last few weeks, but we've certainly had increases in positive tests in the county, and there have been some outbreaks in the counties surrounding ours, and our hospital volumes have been up, as you well know. So
Yes.
are you seeing, is it that the volume of non-COVID business is kind of back up to where it was, plus now in addition to that, we're seeing more COVID here lately?
It does seem to. It seems like I'm seeing now the same number of heart attacks and stroke and non-COVID illness that we were seeing, at this time last year. And now also we're seeing COVID-related complaints. Certainly, a lot of those.
So you've had to change the processes in the emergency department dramatically beginning in March. You're continuing those changes now, different pathways for the COVID versus non-COVID, and how are the staff managing with the sort of the different mindsets of how to take care of the patients?
Yeah, I mean, for the most part, in the emergency department, the patients are treated the same, just in different locations and with different amounts of personal protective equipment. If I'm going to see someone who just sprained their ankle or has abdominal pain but no fever or anything like that, I may use just a surgical mask and just a standard face covering. But then, when you're seeing that cough and fever, we show up in the gowns and the face masks and the N95s and all of that. So it certainly looks a bit different. It takes a little bit longer to get dressed, in between patients. But
Right.
For the most part, we're hanging in there.
You mentioned that the patients seem to be less severe lately, which is good. Are there differences in symptomatology otherwise between then and now?
That's hard to say. I think we've definitely gotten better at recognizing that there are more symptoms than we knew before that are COVID related. I don't know that we were asking before as much about the loss of taste or smell, and now that's a standard question that I ask nearly everybody. So there is that. And COVID-19 is hard to identify. Sometimes it's very classic. You've got fever and cough and shortness of breath and loss of taste or smell. And then other times the symptoms are vague, and that is just really challenging.
Jennifer, you talked about your frustration with testing. I know we've heard on the news that many people around the United States have had to wait 6 or 7 days to get a result of a test, which is kind of like yesterday's newspaper. After a week, I mean, you've moved on. But what's your turnaround time on testing right now?
Well, as of this week, it was around 4 or 5 days. Which is really challenging, right? Because the patient sometimes is sick and has to be admitted, so it really affects how we can treat them. If they're being sent home, they're told to isolate, but then they don't really have that firm knowledge. I mean, we can make the diagnosis of COVID-19 in some situations without a test, but at other times it's really challenging because it's not clear cut and they have a lot of vague symptoms. At one point we had some access to some rapid tests, and we had turnaround times in some rare situations in an hour and other times in 24 hours, and that was so much better. It made things so much better. But then our supply chain support had issues, and that's not a Reed issue. It's more of a state and a nationwide issue, as you mentioned. And now, as of now, I think we're up to 4 or 5 days.
Yeah, I think you're right. I think we need rapid testing. We need to have a result in an hour, and immediately we know what to do. But that's the only question I had, Tom. Do you have any further?
Okay. Well, I wanted to get back to one topic that you touched on, Jennifer, which is the Safe Pathways program. Actually, before the program started, there was a little promo that you were featured in. But what are some of the things that we've done that's particularly emergency department specific that is meant to help people feel safe in the environment?
Well, we have specific rooms that we put patients in that have COVID-19 symptoms. We have the special PPE. We have reduced waiting room space. So we don't allow people to crowd into the waiting room to try to keep them distanced. We try to room right away, although we always did that. We make certainly a special effort for that now.
Okay, good. Well, we appreciate you being here with us today, and you guys are doing a great job. I always say we've got the best emergency department team that I've ever worked with, and that's been true for all 27 years that I've been around Reed, and that mantle keeps getting passed on to new generations of doctors. And I know that you've got several new doctors that have that's just started, right? And they all seem like great people. So appreciate you being here. Keep up the good work.
Absolutely. Thank you so much for having me.
Yeah, thank you, Jennifer, for joining us.
Before we move on, if you could, from a public health standpoint, and there was some guidance that came out of the CDC this week about testing people, and we were talking a lot about testing, where they said one day people who didn't have symptoms, maybe was in contact with someone but didn't have symptoms, didn't need to be a test, then they kind of walked that back a little bit. From a public health standpoint, what does a week and guidance like that kind of changes on a dime do to your messaging and how you and the health department staff actually can talk to people?
Well, I think public health officials and people concerned about public health around the country were horrified at this recommendation by the CDC, a prestigious part of our country and an organization we've always looked to for guidance, who said if someone was a contact with a COVID-19 patient but didn't have symptoms, didn't need to be tested. Well, this kind of flies in the face of everything we've been trying to do. The CDC itself has said that 40 to 45% of people that have COVID don't have symptoms. So this made no real sense to anyone. It kind of caused an outcry in the public health community. Since then, the CDC has kind of walked that back, but they didn't really totally retreat. They said, well, you can test them if you want to. Well, we want to. I think the problem is not too much testing in this country. It's not enough testing. We need to find out who has COVID, and the only way we can do this is through testing.
Based on what either one of you are hearing, and Dr. Bales mentioned the supply chain not being right, are you hearing that things will get better? I know we've been saying that, and you mentioned in one of your posts that I think you posted the 20th show that we did, and I don't know that we ever really expected to get that deep into this, but we are, and this will keep going for a while. But are we getting better as a country with being able to handle this part of things?
Well, I'd be interested to hear Dr. Jetmar's reaction to that, but from my standpoint, it feels like fits and starts. When you look at the state's data on the numbers of tests, it's not a smooth curve up. It's a series of steps, ups and downs. And I think that the testing overall in the state is still well behind what they had targeted to do And I think still the OptumServe sites, they had wanted to have 50, and they're not at that number yet after all this time. They had wanted to have 50 by the end of May, I think.
50 sites, 50 testing sites.
Exactly, and I'm not sure what the number is now, but I'm pretty sure it's not 50. But and the total number of tests are not high enough. You know, we use the rough idea that we want to test enough that the positivity rate is probably in the 1% to 2% range, because that's about that we think that's the background rate that it should be. And if our positivity rate is higher than that, then that means we're not testing enough. And we're far away from that as a state, as a region, as a country. So, you know, I think the problem, as Dr. Jetmore said, is not enough testing. Now, it's possible. My take is that the CDC guidance changed a little bit because they wanted to be responsive to the problem of supply of testing materials. You know, they wanted to, this is my assumption into it, that they wanted to make sure that the guidance was in accord with, you know, areas that couldn't test as fully as that. And so they wanted to make sure that people felt that they had an out, that it wasn't that there were maybe priorities of testing, put it that way. But, you know, testing supply kits and certain components, like the big problem that's been an issue for several weeks is the tips that go on the pipettes that the technicians use to transfer samples into the analyzer. There's special tips for that. There's exactly one country in the world that makes that, a company called Tecan, and I think they're in Switzerland, and they can't keep up with the demand. So, you know, there are challenges like that. I heard the state Department of Health chief medical officer say the other day the state is looking into finding other suppliers, you know, maybe companies that can convert their manufacturing facilities to be able to make these pipette tips, which are not complicated pieces of equipment. So there's that issue for some of the techniques. And then for some of the commonly used testing analyzers in hospitals, particularly the Hologic one that we have at Reed, the Hologic company's been able to keep up with the supply demands of their kits, their media, their reagents and stuff like that. So at Reed, the problem we have is that 2 weeks ago, we only got half of our usual weekly order. And last week, or I should say 2 weeks ago, we got none of our weekly order. Last week, we only got half of our weekly order. And, you know, we're going through 130 to 150 tests a day. And we've gotten down to the point where we've only got enough to go day by day. And that's not at all a comfortable place to be, especially if there's a surge in cases and we have to increase our testing levels. So our challenges are very common around the state and around the country, and there needs to be more of a response to that. And so what we're being asked to do is to look at alternative forms of testing for some situations. There are antigen tests, which are different than the nucleic acid test that we're all loving, and we all know and love that requires the deep nasal swab or the what you characterized once as the dream stealing testing.
And I stole that.
You know, the alternatives to that can use antigen testing, and but the supply of that technology is also limited right now. That's something for the national authorities to kind of get involved in and continue to troubleshoot because we don't have enough testing in general, and we'd like to do a lot more.
I think we've seen a lot of change in testing since this all started. You know, first of all, we had, back in March, we weren't dealing with so many people. You know, the virus was just starting to come into our county. There wasn't as much of a demand on tests, and we didn't have many tests to give. The other thing that's changed is people are more willing to come in and be tested. You know, initially when that Optum site came to town, it was testing 20 people a day, and this was a free test for all comers. And now it's up to 150 to 200 people a day. I think the other thing that's evolved and is Initially, we were all trying to get a specimen from the back of the nasopharynx, and then we discovered that if we swabbed the front of the nose, the test results were similar to swabbing the very back of the nose. And now it turns out that just a simple saliva test, which would eliminate all of these swab tip problems, and it actually could eliminate even having to have medical people. I mean, you can collect your own saliva, send it in somewhere, and it can be tested. So I think we're still short of tests, but the reason is the demand keeps overwhelming the ability of us to manufacture and do more of these tests. It's going to be an ongoing problem, but I want to echo what Dr. Hughes said. Testing is, in the middle of an infectious epidemic, is critical to getting a handle on this, finding out who's infected, and tracing down all those positive contacts.
You're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, and streaming on Facebook Live. It's Ask the Doctors, so let's get to your questions. The health department rates restaurants for safety. Why not the same for stores regarding the compliance with the mask mandate? That doesn't require enforcement, but it does shame stores that doesn't maintain a safe environment. Most stores are not complying today. Public health.
Well, we sympathize with the writer of this question. It makes us all crazy. There is no component of the mask mandate. There's no punitive component. I mean, at the beginning, the governor said that this would be, I think, a misdemeanor and there would be some kind of enforcement. But because of pushback from the public, he withdrew that. So as the health department, we have no real authority to go out and arrest, penalize, fine in any way a store that's not complying. But I would like to encourage our viewers to vote with their feet. When you're in a store like that, you don't feel safe and you need to leave that business and go to a competitor that is doing everything they can to guarantee your safety while you're in their store. As far as public shaming go, you can do that amongst yourselves. I don't think the public health department's going to get into the public shaming business. But I would encourage people to patronize businesses where you feel safe, where they're going out of their way to make their customers feel safe.
Next question. As cold season starts, is it really that time? How does one know if they have a cold or COVID and whether they need to stay home and for how long?
I think that the beginning of the answer is that it can be hard to tell the difference, and someone who has a cold really should stay home from work or school sort of proactively in case there's COVID involved. But there are ways to get evaluated. You know, you can call the respiratory care line that Reed has. You can also have a conversation with a primary care doctor to try to sort that out and decide whether further evaluation is needed. And I think there was a change made recently to the state's guidelines on children in school to kind of make it a little bit easier to get children back into school easier and more quickly based on their symptoms and fever curve and stuff like that. So the point would be to try to minimize the impact of people being out of work or school. But I think at the start, if I wake up with cold symptoms tomorrow, I need to consider, whether this could be the start of COVID-19 and keep myself back from public-facing activities until it clarifies.
The one thing about colds is it's the one disease all of us have had multiple times, so we know what a cold is. Now, that particular respiratory spectrum can be part of COVID, But if you have what you think is a typical cold, but you have all these associated symptoms, loss of smell, fever, maybe associated diarrhea, nausea, headache, many of these symptoms are not typical or part of the usual cold symptomatology. So if that's the case, then I think that would make you want to consult your doctor and ascertain whether or not this is the beginning of COVID.
Is the general statement, if you don't feel well, stay home?
That's a good credo. I think if you don't feel good, stay home.
I don't feel well, I'm leaving. Next question up. If families travel over Labor Day weekend, is it okay to return to school work on the day after Labor Day? I think this is coming to you again, Dr. Jetmore.
Well, I would like to say one thing here. We have seen a spike in COVID cases after every holiday, after Memorial Day, after the 4th of July. So we'll probably see a spike again in Labor Day. And why is this? Because families get together, groups get together to celebrate these holidays. They're in close quarters, they're not wearing masks, and they let their guard down because they know all these people, or maybe it's a large family. If you are, if you're going to get together over Labor Day, get together with a cohort of a small group of friends that you've been, that is part of your cohort. Wear a mask, wash your hands, socially distance. The question, I think, specifically is if you were gone away on Labor Day weekend, should you go back to school? I don't see any reason why you should not, assuming you haven't been around in close contact for long periods of time with someone who you do not know or who may have been sick. But I think it would be all right to go back.
Yeah, I agree. I mean, I think we all have to take personal responsibility for the things that we're doing out in our community-based activities, even if they're private functions like family get-togethers or traveling and so forth. Obviously, if I get home and I get a phone call, oh, hey, Bobby Joe just got diagnosed with COVID, and I was with Bobby Joe a few days ago, then I'm going to have to take steps. So I need to take those seriously, but I don't think we can stop life just because you've been traveling. There has to be more to the story than that.
That's right.
Okay. Next question. I think we just did that one. Okay. Should we be concerned with COVID-19 and the flu season running concurrently? Is our local healthcare system ready to handle any influx? And I turn to
two questions there. First one, should we be concerned? Absolutely. That is top of mind for me every day lately. How could we be ready for both? And, again, it's a matter of personal responsibility. We all really need to emphasize, getting the flu vaccine as widely and broadly as possible, because a big flu outbreak along with an outbreak of COVID could be really problematic for the community and for the healthcare system, and we don't want that. And so we're going to make a big push for the flu vaccine this fall, bigger than usual, and really try to get the rates of vaccination up. Now, the good thing is that I think with the southern hemisphere, which they're just getting over their winter months, they actually had kind of a mild flu season. I'm sure there are many factors for that, but that portends well for us, that maybe our flu season won't be so bad. But one of the things that I've heard conjectured about that is that because everybody's so aware of COVID, and there's a lot more mask wearing and distancing and hygiene going on, that may be having a positive impact on flu by itself. But I think the combination of getting the flu shot and when it's available, COVID shot, and continuing to practice good hygiene, distancing, and so forth is going to be really key this winter, more so than any winter in recent memory.
Yeah, one thing that made me smile, and I think everything you hear about the flu season either says it will be a milder than normal flu season or it will be Armageddon. You never hear a headline that says flu season will be normal. So everybody has a prediction, and when everybody has a prediction, that pretty much means no one knows.
Might be a better question for Christine Stinson, but we're here and we're talking about flu and we're talking about vaccine. Is there any thoughts on when the flu vaccine will be available at the health department, and will there be a drive-through service, or are you going to locations, things of that nature?
Well, there are a couple things in the offing. First of all, I don't know that we know yet about the arrival of a vaccine for the flu season. I do know that we have plans for vaccinating for the flu and for all of the childhood diseases that we normally vaccinate for, because we've fallen behind during the flu epidemic. The health department recently purchased, but has not taken delivery on, a huge vehicle is the word that comes to mind. It's got a couple exam rooms in it, and we'll be able to move this to different sites around the county, Hagerstown or Cambridge City or Centerville. And we plan to use this to provide vaccinations for flu and all of the other myriad of vaccinations that are appropriate, part of the childhood vaccination series for all the residents of Wayne County. So we're taking this whole vaccination thing very seriously and acting on it, and I think we'll be able to make some great inroads into the people who have not been vaccinated.
Well, I'm looking forward to seeing this new whatever it is on however many wheels it's on. You're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, and streaming on Facebook Live, also available on CTV3 in Connorsville. Let's ask the doctors another question. If traveling, do we need to COVID test before returning to school? I think we've kind of covered close to this, but does it hurt?
A lot of this, there are a lot of schools that have this policy. I think a lot of the local colleges, if you were a student coming in from Maryland to go to school at Earlham, you may have been required to get a COVID test upon arriving at school, or one within a couple days of you having left, say, Maryland. So the problem with the COVID test is it's a snapshot in time. If I get a test for COVID 2 days ago and it's normal, that doesn't mean I don't have COVID. It means I didn't have it 2 days ago. So the value of a negative test is somewhat limited. Obviously, a positive test, that triggers a lot of events, and we can do a lot with that information. So I'm not sure I answered the question or not.
Yeah, I'm not sure there's a perfect answer to the question. If you're required to by the school or the school system, then that's what you do. Do you have to from a public health standpoint? I don't think so, but I don't want to discourage people from getting tested. So I think, I think, if I have to travel someplace and I come back knowing what, my own risk issues that come into it. I've mentioned many times that in my clinical work, I work with institutionalized elderly, and to ensure that I'm doing everything I can to safeguard them, I get tested routinely. And if I have to travel someplace, like say I've got to go to a wedding or whatever comes up that I've got to travel, when I come back, I'll probably test again before I go back into the facilities. So that would be analogous. So I think it can make sense in individual circumstances. Everybody's got to kind of analyze their own situation. The only place where you have to is if the school requires it, because I know the public health system does not require it.
I'm going to give you both a minute, or so, your show, so take as long as you want, and just talk to the frustration that you feel as doctors when you have to give the answer of I don't know, because there's a lot of things obviously you still don't know, and the frustration that the community members are feeling because your answers are, I don't know. And I'm sure you all probably get that a fair amount.
Well, I think there's two things that frustrate the public when they listen to me, and I'll include Tom in this, whether he wants to be a willing participant or not, is you've watched us learn about this as we go along. We've told you things in the past that have since proven to be wrong. Back in March, we were telling you it wasn't important to wear masks, that the virus was on droplets and fell harmlessly to the ground about 2 feet from your face. Now we're telling you you have to wear masks. And the reason for this is you're watching us learn as we go. You're watching our knowledge of a hitherto unknown virus that didn't make its appearance in the history of human disease until December of last year. You're watching us learn about it as we go. We've seen miracle drugs put forth, like hydroxychloroquine, that was going to cure disease, and now we've done more clinical studies, and we're saying never mind. It doesn't seem to help. We're finding out as doctors that as soon as somebody has respiratory symptoms from COVID, they need to be on a ventilator. Now we're finding, well, maybe not so much. Maybe we should hold off putting these patients on a ventilator as long as possible. And this is the way science works. You have this unknown disease or this unknown scientific problem. You study it, you come up with working ideas, or what we call hypotheses, because we like these fancy words, and then you test the idea and see if it stands up to experimentation or scrutiny. If it doesn't, it's discarded, and you adopt another idea. And I think this normally happens over months and years. It doesn't happen over weeks. So I think the public gets confused, and I hope not disheartened, because this is how science progresses. We get better every day. But I do hate to say I don't know. I normally I never say that to my wife or grandchildren, but I've had to say it multiple times to the viewing public, and for that I apologize.
Well, all that is true. We're seeing, there's any number of ways to discuss this. We're seeing, what in normal times would probably take 20 years to change this much on a topic in healthcare is changing in 6 months or less. And that's just the way things seem to be with a new emerging disease where, we're trying to fight it to the best that we can on limited knowledge that's increasing daily or changing daily. And that's just the way it is. And, I would say of 100% of what we think is true today, probably 80 or 90% of it is still going to be true 6 months from now. I just can't tell you for sure which 80 or 90% of it is. Some 10 or 20% of it's going to change at least. But this is an age-old dilemma in healthcare and medicine. We don't always have the yes or no answers to things. In fact, most of the time, we have maybes. We have with provisos and such like. And generally, the best we can do in many, many situations, whether it's COVID or something else, is just reason through it, say, based on what we know and apply to your situation, here's what I think is the best thing to do. But there may be multiple options. And at the end of the day, patients usually have to decide for themselves how they're going to do it. And there's an analogy here with COVID. Every individual person, every individual family have to decide how they're going to approach this for their own safety and the safety of their vulnerable family members and friends. We can give direction and guidance, but you have to go do it.
You're watching Ask the Doctors on WGTV Channel 11. We're going to get to a couple more questions, and we're going to look at your weekly numbers, so let's bring those in. As a parent of an RCS student, we finally received the call about a positive case in our particular school. How closely is the health department following the school systems and the positive cases already present? What information can you share about those specific cases?
Well, the health department is in constant communication with school superintendents, and when a child is diagnosed as being COVID positive, the health department's notified, and we begin to do contact tracing. We find out who that student was in contact with, and the student himself, if from the time of the test to the time he became symptomatic, will need to be isolated for 10 days. And his contacts, that's people he's been around for 15 minutes or longer, closer than 6 feet, they'll have to be isolated for 14 days. So we're very interested in this, and we're in constant communication with the schools. One of the things we've tried to do is have assigned seating on the school bus, in the cafeteria, in the classroom, so that if one child in the school gets COVID, we don't have to shut down the entire school. We just have that cohort of the close contacts around that child. So we want school to continue. We want school to go on. We want to deal with all of these little minor outbreaks, isolate. The isolation period will end, that child can come back, and we'll go on.
The second part of that, how specific can you get about what you know?
Well, we prefer not to. Obviously, we're not going to identify any of the patients, and we prefer not to identify the schools. We have had to isolate an entire junior varsity football team from one of the schools here in the county. We've had to isolate an entire varsity football team from another school here in the county. But I'm loath to reveal who those schools are. Just to protect it's just not part of public health. We like to protect the identity of our patients and of our institutions.
Cool. Next question. As you work with the school systems to help make decisions about the safety of our children, do you talk about thresholds for closing schools? For example, is there a number of positive and quarantined cases needed to recommend Richmond High School go strictly virtual?
You know, I've been asked this question before, Eric, and I've heard this question posed before, and we do not have a number. We do not have a cutoff number of a threshold. I think what I've seen so far as the school's been in place is that we've been able to deal with the COVID that we have in the school. We've been able to use time-tested methods that public health has used for 100 years to isolate and control these outbreaks, and we'll continue to do so. But we don't have a number in mind that if it gets to this many cases that the school will be closed.
You're watching Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, and streaming on Facebook Live. We are under 10 minutes to go in this week's program, and we want to make sure we give Dr. Huth a chance to update you on some of the numbers in the community and what they're seeing at Reed Health.
Sure. I think I've got 3 exhibits, and you can just start with the front one, Stephen. If you want to go back 2 pages, possibly. There you go. These are the Wayne County numbers per week. The numbers are more definite through August the 15th, although it looks to me like they've been revised down, and that's something Christine is going to double check on. So I would say those numbers may be tentative as well. But if they hold up, then what it looks like is the county had a peak in the week ending August the 1st. And then since then has trended down a little bit. We hope that trend will continue. For sure, the week ended last Saturday, the 22nd. That's definitely preliminary, and I'm sure will be adjusted further up or down.
Christine told me that on the 28th we had 43 cases, which would be another week out from your graft. So
Okay, yeah. So I did not include any numbers from this week that will end tomorrow. And so basically, so far, 48 cases for the week is what you're saying. And probably that will go up. So there's that one. And so I hope that we're over our hump in the county, but we still have significant numbers of new cases, and we don't want to, relax, I guess would be the point. And, so we still need to be vigilant about what we're all personally doing. The next graph, Stephen, has, these are the age groupings of cases broken down into basically 2 months increments. We have April, May as the first bar, blue bar. June, July are the kind of orangish bar in the middle. And then it'll be August and September once September rolls around in the gray bar. And we still see this pattern that I've referred to before, in that the younger age groups, particularly 10 to 30, 10 to 19 and 20 to 29, where we've had significant increases in the percent of cases in that younger age group, and declines in percentage in the oldest age groups from 50 and up. And that's something that has been noted nationwide. And I think it's maybe helping to drive the lower severity of illness that Dr. Bales referred to in the emergency department. There are fewer very sick cases coming through her shop, and I think it's because we're not seeing as many cases in the older age group, where we have the more vulnerable people who are at risk for more severe illness. And I guess that's a welcome trend in a way. But the 10 to 30 age group, of course, is right there in the prime of the school age and college age kids, and so it's not like great news, but it's better than it could have been. If you go to the last one, Stephen, which is the Reed cases, and these are average cases per day in a particular week. And so the week so far, which will end tomorrow, we have an average of 31 cases in isolation, average daily census of 18 known positives, and an average of 1 patient on ventilator. And those are still on an upward trend since July the 11th. But it's nowhere near overwhelming for the health system. Somebody asked a question before about at what point is Reed going to be overwhelmed, and we're far, far, far from that. We think we can handle multiples of this if we have to. We just would rather not. And the challenging part would be able to maintain other services along with taking care of a lot of COVID patients, because we don't want to delay people having their hips and knees replaced, and people need those things too. We don't want to shut those down like we had to do in the spring. So again, it comes back to everybody doing their part to stay healthy, and therefore stay out of the hospital and make sure that we have plenty of capacity to manage all this. And so far, we're good.
Okay. We've got 5 minutes left to go in the program. Need to, thank Steve Bonwig, Ryan Harris, and Michelle Thompson, staff members who you don't see, for helping us do this. We've got about 4 minutes, so we're going to try to get one more question in, and we're going to keep your answers pretty close here. So if we've got one more. Should employers in Wayne County require their employees to self-quarantine after they have traveled outside the state? If yes, how would this apply to employees living across the state line? Whoa.
I don't see why they should, out of hand, require them to self-quarantine, assuming they haven't been in any large gatherings, that they've social distanced, that they've worn masks. And, the state line really doesn't have anything to do with it. The virus doesn't care about the state line.
I guess the way I would look at this is, I don't know what they should do. They could do that. They could. The businesses can do that if they like. But I'm not sure if they really have to. If they wanted to take a targeted approach, I think what might be more justifiable is if I have employees who are traveling to places in the country or even out of the country where there is high incidence of disease, and on a targeted basis, maybe they should test before they come back to work or should isolate a few days. That's a decision a company could make. I mean, I remember that in the beginning of the pandemic when there was concern about different parts of the world. I mean, Reed had employees who had been to China recently or were coming back from Italy, where there was a huge outbreak, if you recall, back in the March-April timeframe. We actually did require employees coming back from those kinds of places to isolate for a time, and that's when we didn't have testing capability and that kind of thing. So we've done it. I don't foresee us doing that in the future because we have a better understanding and we have the ability to get tests. So I could see a company maybe deciding to, but I'm not sure it's really necessary.
I think it would be easier to ask your employee to test than to isolate.
Sure.
Okay. We're going to wrap it up there this week. Thank you for your time once again, Dr. David Jetmore, Wayne County Health Officer.
You've done a fine job, Eric. You've shaken the rust off and gotten right back there into the...
Thank you. Dr. Thomas Huth, Vice President, Medical Affairs at Reed Health, and also still Wednesday evenings on WHIO TV?
Yes, absolutely.
5 p.m. hour, I believe?
It's fun. Like doing it. And welcome back, Eric. We're glad you're here.
Thank you. Glad to be here. Appreciate your time, and we'll see you again next Friday. Don't forget the free COVID testing site is available Monday through Friday, 8 a.m. to 8 p.m., 601 East Main Street. You can register by visiting lhi.care/COVID testing. You can also reach out to the health department if you are in need of assistance. Richmond Farmers Market continues to go on. You got to continue to eat. Good eating habits, I think, the doctors would tell you are really a good idea. You can do it online if you don't want to go, but it's every Saturday from 8 a.m. to 12 p.m. And then, of course, they have their Tuesday night Twilight Market at Jack Elstro Plaza, 4 p.m. to 7 p.m. Keeping healthy with a meditation walk at Hayes Arboretum is incredibly important. That happens Thursdays at 6 p.m. Relaxing walk, free and open to all, 15 and over. Also with the Richmond Parson Recreation Department, Reed Health Community Benefits, their Richmond Walking Club is back. That's Thursday evenings at 7, so you can get a couple of hours in. Walk at Hayes from 6 till 6:45 or so. Get over to Glen Miller Golf Course, start at 7, and go there. And virtual dementia caregiver support group is meeting. Their meetings are held the last Thursdays of the month from 2 to 3. You can register online. There's a number there, or you can call. Space is limited, so definitely register early. Thank you very much for watching this week's Ask the Doctors on Whitewater Community Television's WGTV Channel 11, WCTV Channel 21, streaming on Facebook Live, and also available on CTV3 in Connorsville. We will be back next Friday at 2 p.m. for another Ask the Doctors. Thank you very much for watching. Hope you have a great weekend. As always, I wish you well.